Some of the biggest unmet needs that we currently have in CLL are in part related to the successes that we've had with our newer targeted therapies. It's undeniable that patients are doing better and living longer with targeted therapies that take advantage of our knowledge of the biology of the leukemia to design specific drugs that target key metabolic pathways or survival pathways that are essential for the survival of the leukemia cell. And these drugs have very high therapeutic index, they're very well tolerated, and they really have made a difference in terms of prolonging the survival of our patients. However, like anything, we have some problems, particularly with a subset of patients who develop resistance to these targeted therapies. And this is one of the biggest unmet needs that we currently have. Patients who have high-risk characteristics such as the expression on their leukemia cells of unmutated antibody genes, or mutations in the gene TP53 that's oftentimes associated with deletions in the short arm of chromosome 17 or deletion 17p represent a significant problem. These patients typically have a shorter progression-free survival on any of these targeted drugs than patients who do not have these characteristics. And they can develop mutations sometimes in the genes that are encoding the proteins that are targeted by the targeted therapy. Notably in this case is the development of patients who develop resistance to the so-called BTK inhibitors, such as ibrutinib or acalabrutinib or zanubrutinib. It's well known now that patients can develop a mutation at one specific site at position 481 and therefore develop resistance against this whole category of drugs, which we now term as covalent inhibitors, because these drugs form a chemical bond with the BTK. So a new category of drugs have been developed that do not require this covalent bond, and they can respond to this drug. However, we've actually had patients develop resistance to this newer category of drug. We're very excited about the development of so-called BTK degraders. These are like the stealth spy protein that go in there and target the BTK for enzymatic destruction inside the cell. And so you can actually see degradation of the protein, and that might be expected then to mitigate the problem of having resistance because of mutations in the protein. However, more recently, we've actually identified mutations within BTK that can actually influence the susceptibility to these new category of drugs. So this is somewhat of a cat and mouse game that we're playing now with some patients who develop these resistant mutations. The key questions are, why did they develop these mutations in the first place? And two, how can we leverage our existing knowledge of the biology and combine some of our targeted therapies so as to achieve successful long-term progression-free survivals and improve overall survivals for all patients?